So for our presentation, we did the hip joint. As you can see in this picture, there's many different components of the hip joint. As you can see, you have the head of the femur, iliac fossa, the lesser trochanter and the greater trochanter. Together, the width of them makes the widest part of your hip. It's in, if you want to bring down my hip, it's in this area right here. So it's pretty wide on your body. There's 3 unique structures we found in the hip. The acetobellum, it's a depression which is cup-like. It's on the outside part of the pelvis. As you can see, it is right here. As you can see, it's the depression, and it's where the ball socket forms. So it's where it goes in. The second one we found is the fubofemoral. It's on the anterior and inferior part of the of the hip joint. It prevents unnecessary abduction and medial rotation. So abduction is when your leg goes out, and medial rotation is when it twists. So it prevents that. That is located on the posterior side of this. You can't see it in the picture, but it's on the back of it. And also on that area is the ischiofemoral. It's a posterior ligament of the hip joint. It attaches the pelvis and the greater trochanter, which is the upper part of your femur. It stops, again, with, like the fubofemoral, it stops excessive medial rotation of the femur at the hip joint. As you can see, it's again, it's on the part of the neck right here in the back, right where the other one is. Also, in the hip joint, you can see, as we talked about in class, there's articular cartilage. So that is what is attaching the ball and hip joint. So I thought that was pretty cool. The functional abilities of the hip, the obvious one, it allows us to walk, jump, skip, whatever. Pretty much all the activities we do with our legs is because of our hip. The ball and socket structure is what allows us to have such free range of motion. So you can do yoga, stretch, pretty much whatever with your legs. It bears our body weight, which is kind of a lot for your upper body. So it makes it sort of like don't collapse. And it bears force of strong muscles of the hip and the leg. And it also is the connection between the leg and the skeletal structure of the trunk and pelvis. So your trunk and your pelvis up here.
There are 6 different major movements which occur in 3 different planes. The first goes in the sagittal plane, which includes flexion and extension. Flexion is when you bring your thigh forward, and extension is when you bring your thigh backward. The second set of movements is in the frontal plane and includes abduction and adduction. So as you can see here, abduction moves outward, and adduction is when you bring your thigh across your body. And the last set of movements is in the transverse plane, which includes medial and lateral rotation. So as you can see, lateral rotation is when you turn your foot outwards, and medial rotation is when you turn your foot inwards. So I have a quick video just to show that. So here you can see the flexion and extension, and then you can see the rotation for medial and lateral in this one. And then the final one, you'll see adduction and abduction. Abduction is the coming out, and here's the adduction. So each of these movements has a different range of motion. So when you bring your thigh up for flexion, it can go from 110 to 130 degrees, which is the largest range of motion out of all the movements. Extension, which is the equivalent to that, but backwards, only goes 30 degrees. And adduction and abduction are pretty close to one another, but adduction moving across your body is only 20 to 30 degrees, and abduction, which is moving away from your body, can go up to 45 to 50 degrees.
Okay, so there are 5 main weaknesses in our hip joints, and the first one is the neck of the femur, right here, and it's just because it's such a thin area that it's really prone to fractures compared to other parts of the hip. And then we have the posterior and inferior parts of the socket. So It's the back of the socket, but also the lower portion of the socket that's really weak, because that's where all the stress is going to be. And then the rest of the other three are actually parts of the ligaments of the joint. So the first one is between the arms of the anterior iliofemoral ligament, and the iliofemoral ligament is right here on the neck of the femur that connects the hip to the femur. And right here in this groove is where the weak spot is. And then we have between the pubofemoral and the inner edge of the iliofemoral ligament. So the pubofemoral ligament is right here on the inside, and the iliofemoral ligament is on the outside. So right where those two meet is where the weak spot is going to be. Now, the last one is the lower posterior part of the neck of the femur between the two branches of the ischiofemoral ligament. So the ischiofemoral ligament is right here on the neck. We talked a little bit about it earlier. And the weak spot is going to be right here between the two branches of the ligament itself, so right here in that groove. Now, there's a couple of injuries. Some of them are more common than others. We're going to start with bursitis, which is just the inflammation of bursa. And bursa are little fluid-filled sacs that help protect against friction, either between bone to bone, muscle to bone, between ligaments and bone and muscles, anything that would cause friction when they rub against each other. Now, this could either be caused by overuse or an injury. I actually had bursitis before because I got kicked in the hip and I couldn't walk for a while. It's a little painful. But there are about 20 bursa in the hip. And we have 4 of them in this picture that are shown, which are in blue. And these are in places that have high friction. So these are all here to protect the muscles, the bones, any sort of attachment point so that they don't get damaged or worn away. And of course, here are the more common things like the strains, which is just an overstretching or a tear of your muscles or tendons. And the muscles that would be involved in this are your quad, your glutes, your hamstrings, anything that would attach to the hip joint itself. And then you have fractures, which talked about how that happens more often in the neck of the femur. You don't really see them much anywhere else. Occasionally, in older people, you get a hip fracture in and of itself. But then we have dislocations, which is the head of the femur actually slipping out of the socket that it was made to fit into. Now, we have a handful of diseases and disorders that we're going to talk to you guys about. First one is osteoarthritis, which is a chronic disorder that gradually deteriorates the cartilage in the joint. So we talked a little bit about articular cartilage, and Caitlin pointed that out to you. So that would be the cartilage that would slowly deteriorate over time, which causes a lot of friction and a lot of pain in the joint. So it would be where the femur fit in right here, all over the top of the head of the femur. And now we have aseptic necrosis, which is an inadequate blood supply to the head of the femur, which causes cell death, which means the bone tissue there would die. And this also can cause a lot of pain and stress on the joint itself. And the last thing on this slide is alopecia of the acetabellum, which is right here. Caitlin pointed it out earlier on the actual hip picture. And it's this tissue right here inside. And what happens in alopecia is the defective development of the tissue there itself. It happens in young children around the age of 8 to 10, something like that. And it's just that it doesn't develop properly, so it can cause pain, it can cause problems with movements, any sort of those things.
Some further diseases and disorders involve the coxa valga and the coxa vara. These include deformities of the hip joint itself. So in the coxa valga, as you can see here, the angle between the neck and the shaft, so the neck and the shaft here, is much larger than the normal angle, so it averages around 100. The second one is coxa vara, which is the deformity of the hip involving the decrease in the angle between the neck and shaft of the femur. So as you can see, the neck is here and the shaft is here, and it's only at a 110-degree angle, as opposed to the 130-degree angle of the normal and the 140-degree angle of the coxa valga. The difference between the coxa vara and the coxa valga is that you could, in very extreme cases, probably see the effects of coxa vara, in that your hip would probably be bowed, or possibly your thigh is when you were walking.
So we found several different hip technology. If you fractured or suffered hip loss, bone loss. The first one we found was the Veralast technology for hips. It's made out of oxygen and expo material. It's really good too because it has no risk of fracture or chipping. The material it's made out of is pretty durable. It's also okay for people who are allergic to metal, so it's okay for metal sensitive people. They won't have any reactions or any of that to worry about. It also is good because it has less polythin wear, so it's not made out of a lot of material that won't be good for your body. This actually will increase your range of motion better than if you weren't to have it, so your hip would have a greater range of motion after the surgery, which is pretty cool. It also is greater stress distribution of your weight, so you'll be able to carry more stress after the surgery. The second one we found was the Pinnacle Hip Solutions. This allows for active patients to remain active, which would be good for Carolyn or Ashley because they're with soccer. And if they got their hip, if it fractured or whatever, like they'd be able to fix it and remain active right after. The next one we found was artificial hip repair, which is usually given to people of older age, usually older than the age of 55. It only lasts 10 to 15 years, but if you're older and you're getting it, you're not going to really need it for that long. Though, because they have hip revision. As you can see, it's for those who have had hip replacements in the past, but they're not effective anymore and they've kind of worn off. So if you did get a artificial hip replacement over the age of 55, you'll obviously be able to get another one to revise it and make it better. I know my grandma, she got the artificial hip repair when she slipped on the...
Stop making stuff up!
I'm so sorry. I'm so... Fuck.
Just don't make it up.
Okay,
just straight up.
Okay. No, it actually did happen though. My
Oh, really?
asshole, yeah.
Oh.
Okay. So I know my grandma got the artificial hip repair when she fell in the ice. She was about 75 at the time, and she got this. But she didn't need the hip revision because it lasted.
So now we're going to go into our possible improvements on the hip joint. And we had a little bit of problems with this just because we realized just how stable the hip joint is because of all the tendons and ligaments that attach to it and keep it together. So it's kind of hard to actually pop it out of place or fracture it in general. But we talked about how the neck of the femur is very weak earlier. So we thought if we increase the ossification in this area earlier on in life, then later when we're no longer able to repair our bone tissue as well, maybe then this extra ossification would hold up the neck of the femur so that you wouldn't fracture it as often. And we also believe that it might decrease the chance of having coxa valga or coxa vara because it strengthens the neck of the femur so it will no longer decrease or increase the angle of the neck with the shaft. And that's it.
Ta-da! Oops.